Hello, everyone. We'll get started here in just a moment. Welcome to the Silver Hill Hospital Grand Rounds program. We'll just wait a few beats as people settle into their Zoom boxes. All right, I will go ahead and get started. I am Dr. Jeff Katzman, the Director of Education at Silver Hill Hospital. And we are so delighted to have you join us for our virtual Grand Rounds with the other Dr. Katzman, Dr. Joanna Katzman, presenting on the topic of how to safely care for patients with chronic pain and substance use disorder. I will turn to Dr. Andrew Gerber to introduce her in a moment, as I really don't want to mess up this introduction. First, 2022 Grand Rounds series, our program is in full swing as we enter our second quarter. Our April Grand Rounds welcomes two significant topics. The first, gender diversity and mental health, a developmental approach, presented by Dr. Aaron Jansen. And the next, technological addictions, the new frontier of addiction psychiatry, where we welcome back Dr. Petros Lavunas. We really hope you all can join us for those presentations. All of our upcoming Grand Rounds can be found on our hospital website calendar under resources and blogs. And you can see the year's remaining Grand Rounds, and registration links are open a few weeks in advance of each event. Now, a few housekeeping details for today's presentation. Questions are an important component of our Grand Rounds, and we will take some time toward the end of the lecture today to hear your questions and comments. Please use the Q&A link at the bottom of your screen. You can submit a question anytime during the lecture, either with your name, or if you prefer, you can submit it anonymously. We will have time for questions and answers at the conclusion of the presentation, when we'll also have the opportunity to hear reactions or questions from our panel who will appear, including our President and Medical Director, Dr. Andrew Gerber, as well as our Chief Clinical Officer, Dr. Michael Grote, and Dr. Ryan Wade, one of our attending psychiatrists with a specialization in addictions and a recent graduation from the Yale Addiction Psychiatry Fellowship. An evaluation survey will pop up in the browser when the webinar ends, and please kindly complete the survey to receive CME and CEC credits for today's lecture. We'll also email a copy of the evaluation survey to today's participants. Of note, there's a good deal of content in the presentation that we won't have time for. I think like 147 slides, which we won't get to all of that. But Dr. Katzman wanted participants to have the information, which will be available to all through the Silver Hill website by Friday. And as I mentioned, a link to the recording and a copy of the slides will also be sent with the certificate after the evaluations are completed. During today's presentation, Dr. Katzman will present a case at one point, and we invite you all to use the Q&A function to type in your ideas and responses to her questions. I will appear at that time to facilitate for a moment, as she won't be able to see the Q&A chat as it rolls in quickly. Finally, disclosures: all the planners, speakers, or individuals in control of content for this educational activity have no relevant financial relationship to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. It is now my complete pleasure to pass the baton to Dr. Andrew Gerber, President and Medical Director at Silver Hill Hospital, who will introduce our guest today, Dr. Joanna Katzman. So, Dr. Gerber, I turn to you.
Thank you, Jeff, and it is an honor to be doing the introduction today. I suppose there are three versions of why I'm doing the introduction rather than you. There's one possibility, and our audience can decide which one they find the most convincing, is that it was so that you wouldn't mess up. Number two, which I kind of like, is the idea that we take conflicts of interest so seriously here at Silver Hill Hospital that any even appearance of conflict of interest should be avoided. And we would not want anybody misunderstanding praise of Dr. Katzman, Dr. Katzman who's speaking today, as coming from her husband. But my personal favorite reason is because I think Joanna is one of the most special speakers we have all on the agenda all year long, and I really love the idea that I get to introduce her, because she is an extraordinary person, and what I would really consider to be a Renaissance, a woman Renaissance person who has covered so many different areas. And so it feels really, really special to have her speaking to you all today. I'll give you a brief overview of her background because I don't want to take time from her presentation that I know I'm looking forward to, and I'm sure you are as well. So Joanna has a very illustrious background in both her education and her career. She went to Stanford as an undergrad, then to Yale for medical school. And I like to think that it's not a total coincidence that we have been able to pull both Jeff and Joanna to living in Connecticut and being associated with Silver Hill because of her previous connection to Yale, which as you all know, we have as well. And then returned to LA where she did her residency and fellowship in connection with UCLA and her let me make sure I get the name of it right, but her fellowship through neuro rehab and ultimately leading to her career in pain management. So through her career, she has worked in a number of services. She ran a multiple sclerosis clinic. She worked in an ALS. She was medical director of an ALS center as well. And then in 2008, something really quite extraordinary happened, which is she was one of the founding members of Project ECHO at University of New Mexico. And I know many of you have heard about this, and it's something that I think we've all been learning about from Jeff and now Joanna, an effort that was well ahead of its time in thinking of ways to use virtual means to bring clinicians from multiple locations together electronically long before COVID was even on anyone's radar. And I think really has proven to be a powerful way of increasing access and building community. And I think they knew something, before the rest of us figured it out, which is that if you're going to bring people together, it's not just going to be in lecturing and having them put a picture up on the screen and listen, but rather having people participate and ask questions and share their own clinical cases and all the rich things that Project ECHO has to offer. So it is no coincidence that Project ECHO was such a major success at University of New Mexico and now really worldwide because Joanna was involved right from the beginning. And I think we're going to see today part of why people have been so eager to have people like Joanna participate. My own introduction to Project ECHO when I first learned about it was to attend another Project ECHO seminar that she was involved in leading, and that was on climate change. And I know she still does that. And I was just blown away by how this complex topic was brought together in a real and clinically compelling way through her leadership. So I think we're really privileged to have her here today. I will mention one other area of Renaissance specialty, which some of you may not know, which is that Joanna has a career as a really expert tennis player. And at one point was even a doubles partner with Tracy Austin, who some of you may remember as being a former #1 ranked women's tennis player and Grand Slam winner. So Joanna has many, many talents. She's also just an absolutely lovely person. And it's been a pleasure to get to know her and to think about ways that her expertise in neurology and neurosurgery, which is where her current position as a professor at University of New Mexico is both in neurology and in neurosurgery, how that is related to the work we do here at Silver Hill for mental illness and addiction. So I hope we hear way more from Joanna in the future. But on that note, I'm going to turn it over to her, and I'm really looking forward to her talk and then to a great discussion afterwards. Over to you, Joanna.
Thank you, Andrew. Can you all hear me? Yeah. Okay. Thank you, Dr. Gerber. Thank you, Dr. Jeff Katzman. Wanted to really thank you, Dr. Gerber, for that really too nice introduction. And I wanted to thank Dr. Jeff Katzman, Dr. Gerber, Jane Cullen, and Ann Romano from the education team for inviting me, Dr. Grote. It's really an honor to be here today at Silver Hill to provide this talk. I've been really looking forward to it for a very long time. And I'm really happy today to give this presentation about the complex situation we have here in the United States, the tremendous overdose epidemic of opiate use disorder and substance use in the United States. The Tetrad of chronic pain, substance use disorders, mental illness, and suicide. It has escalated dramatically since the COVID-19 pandemic hit in March of 2020. So I'm going to share at the beginning of my talk a little bit about the epidemiology of this tetrad of these chronic pain, of these public health crises. And then the second half of my talk, I am going to kind of illustrate how these four public health crises, namely chronic pain, substance use disorders, mental illness, and suicide, can all interact and intertwine in one patient, and how we might safely consider caring for a patient with these conditions. I do not have any conflicts of interest or disclosures to present to you today related to this talk. And the learning objectives are to better understand the epidemics of chronic pain, substance use disorder, mental illness, and suicide, to learn how the COVID-19 pandemic has really increased the severity of these public health epidemics, as well as other medical conditions across the United States and really globally. And then to increase your knowledge and your confidence regarding the safe management of patients suffering from chronic pain and specifically opiate use disorder. Well, there's many facts, and they're not great facts, but facts that we really need to know in order to understand really the size, the enormous burden that these four epidemics are playing out here in the United States. We know that at the very least, 50 million people in the US suffer from chronic pain. Now, in 2011, the Institute of Medicine reported that over 100 million people in the United States suffered from chronic pain. And then the National Academy of Medicine came back and kind of reduced that number in half. But regardless, we know that between a third to a sixth of all Americans at some point are in every day are suffering from chronic pain, really affecting the quality of their life, their ability to work, their ability to be with their loved ones, their family members, and really interacting actually with possible mental health diagnosis and possibly putting them at risk for substance use disorders. We also know that back in 2018, before the COVID-19 pandemic hit, that over 164 million people over the age of 12 were substance users in at least 1 month in terms of drinking alcohol, using a tobacco product, and a little less were using an illicit substance. I'm going to turn to the last bullet on this slide. Also in 2018, if you remember, there was a huge spike in suicides between 2015 and 2018. There were over 48,000 recorded suicides, up from 42,000 in 2014. It has slightly stabilized during the pandemic, but it's unclear whether or not that's due to reporting or not. And then since the COVID pandemic, the number of opiate overdose deaths has escalated dramatically. Over 2 million people in the US have an opiate use disorder, and over 100,000 overdose deaths have been recorded in 2020 alone, which is 274 people a day on average. And before the pandemic in 2018 and 2019, the numbers of people dying per day on average from an opiate overdose death was approximately 130 people per day. So it's more than doubled in the past 2 years. We also know that over 9 million people in the US are misusing opiate analgesics. And we'll talk about misuse later. more specifically, but opiate misuse really means taking opiates for a different reason from which they were prescribed, either to the patient who's misusing it or to somebody who is using opiates not prescribed to them, but for other reasons. And we'll talk about what those reasons might be. Before we move on, though, I did want to give you some hope and resilience that there is perhaps some resources on the way. President Biden just last week, he signed the Dr. Lorna Breen Healthcare Provider Act into law. It started out as a House Bill 1667. And if you remember, Dr. Breen was an emergency room physician at Columbia Presbyterian Emergency Room. She died by suicide, and the apparent cause of death was depression and extreme burnout from the work that she was experiencing during the pandemic, as well as probably other causes. This Dr. Lorna Breen Act will raise awareness regarding physician and other clinician PTSD, suicidality, and burnout in the basically in the healthcare provider field. And it will actually raise awareness also into substance use disorders, chronic pain, and mental health diagnoses, and bring research funding and clinical funding to academic medical centers. And as I proceed along this talk, it's really important to know that these diagnoses of chronic pain, substance use disorder, mental health, and suicidality are just so common that most clinicians have family members or friends who also suffer from these conditions. So increasing awareness for you all not only helps your patients, but can help you and those you love. So beginning with pain, which really is how I got into my work and my love for taking care of patients suffering from chronic pain. It's how I got into my work with substance use disorders as well. Pain is a very major public health issue. As I said before, it affects an estimated 50 to 100 million Americans. It also costs up to $635 billion per year in medical treatment and lost productivity. And compared to people without chronic pain, people with chronic pain have roughly 3 times the rates of depression and anxiety disorders. In addition, people with chronic pain have at least 2 times the risks of completing suicide. Especially patients who have facial pain, trigeminal neuralgia, atypical facial pain, and chronic headaches, such as migraine headaches and mixed headache syndromes. I just wanted to turn now to the overdose epidemic. As you know, in the past 5 years, we're really suffering from we've gone from kind of a prescription opiate overdose epidemic to a heroin overdose epidemic, now to kind of this synthetic fentanyl, illicit fentanyl overdose epidemic. But I wanted to just show you the table on the left, which is 2005. And if you can see, it's a little hard to see perhaps, but if you can see, I sit in New Mexico at the University of New Mexico. New Mexico led the country in 2005 with a death rate of 20 per 100,000, with the predominance of deaths due to heroin in northern New Mexico. And northern New Mexico still has the highest counties in the country of people dying in Rio Arriba and Mora and Taos County in the northernmost parts of the state, due to not only black tar heroin, but now, unfortunately, the illicit fentanyls. But if you look at these states, you see they're spread around the country, not so much on the West Coast, but as far west as Colorado and Arizona, not into California or Portland or the state of Washington. But now if you look at the right-hand table, you'll see that now the #1 state in the country, as you probably know, are kind of the states of Appalachia. West Virginia, over the past 5 to 10 years, has really led the country. West Virginia, Kentucky, Tennessee, with Ohio and Delaware in the top 5. I also wanted to point out that Connecticut is now in the top 10 with 39 deaths per 100,000, and in 2020 had over 1,300 opiate overdose deaths. New Mexico is right there behind Connecticut. And even though New Mexico is now, probably number 10 in the country with 784 deaths, which is 784 too many deaths, at number about 10, as you can see, compared to 2005, that is more than twice as many deaths when we were ranked #1 in the country in 2005. So you can see just the enormous escalation in people dying unnecessarily of an opiate overdose. So looking at opiate overdose deaths now during the COVID-19 pandemic, over 100,000 overdose deaths occurred in 2020, the 12-month period ending in April of 2021. This was about a 28.5% increase from the prior year. And just take a look for a second at the map. You can see West Virginia in dark green, really far and away leading the country. And we can talk about reasons why, just the economic depression in this state. And you can see the surrounding states of Kentucky and Tennessee and Pennsylvania and Ohio, kind of states of Appalachia around that state. New Mexico still is high in the list, and Maine and Connecticut are still high as well. Kind of moving on to suicides as well. This is a very different distribution of the map in terms of different from the opiate overdose death map. And it's suicide mortality by state. And increases in suicide really occurred between 1999 and 2018 before declining in 2019. In 2020, there were over 45,000 suicide deaths, most by gun violence. And if you look at the states of Montana, Wyoming, Colorado, and New Mexico, people call it kind of a wall there that kind of separates the kind of West Coast with the Midwest, if you will. These states are all extremely rural, extremely impoverished, and all have very loose gun regulation laws. And most of these deaths in these states are related to gun violence. In terms of suicide during COVID, the suicide rates due to firearms continue to rise. And suicide in women due to firearms during COVID has now surpassed poisoning or taking pills as the leading cause of suicide. Dr. Nora Volkow, who is the director of the National Institute of Drug Abuse, was interviewed in last spring, talking about, a tale of two crises, fighting the overdose pandemic and also fighting the COVID-19 pandemic, and how do we kind of overcome the overdose pandemic during COVID. And she kind of talked about the difficulty with decreasing opiate overdose deaths during the pandemic, and why can't we get more patients with substance use disorder into treatment. And she talked about 5 possible reasons: the stigma of substance use disorders, the isolation of people with substance use disorders, even more so during the pandemic, the loss of work with people with substance use disorders. It's already difficult for people with substance use disorders and mental health problems getting work, but the pandemic even predisposed folks to more economic depression, tremendous loss of economic stability. People were losing homes, and a much more increase of people experiencing homelessness. But then she also raised hope with increased ability to use telemedicine. And if we could, work with some structural reforms such as social justice and justice system reform. Not an easy task, but she always likes to propose some hopeful signs in here. I just wanted to turn back, though, to death rates from prescription opioids. These are not, where I'm not talking now about, death rates from prescription opiates and heroin. As you can see, the death rates from heroin were on the rise kind of in the mid 2000s, but really stabled off in about 2015 to 2017. But what you can see on this graph with the dark blue is the dramatic rise in the kind of the illicit fentanyls. And I apologize, but the title of this slide should be Death Rates from Prescription Opiates and Illicit Opiates. And what we're seeing now is that by far and away, most people are losing their lives from the illicit fentanyls. And we're not talking about people are losing their lives, not just who have been taking illicit drugs for decades, but even people who are experiencing recreational drugs for the first or second time, and might have been using methamphetamine or even cocaine recreationally in college, and are trying cocaine for the first or second time. And the first or second time they take it, it's been laced or mixed with fentanyl. And what's happened all over the country is that person might not wake up in the morning because they did not know it had fentanyl in it, and they were naive to this strong opioid. So I mentioned that I would talk about what is opioid misuse, which is a major public health issue and is one of the reasons why people start from prescription opioids and obtain from their doctor, and then go down the road of misusing opioids. Opioid misuse is really using an opioid not for which it was prescribed. Perhaps a doctor originally gave a patient an opioid for a severe neuropathy, and then the patient realized that the opioid helped them sleep, so they started using it for their sleep, and they still continue to obtain that opiate for their doctor, but they're really using it for their sleep. Or they realized that the opioid was a mood enhancer. Or perhaps the patient is now giving this prescription opioid to their spouse or to their niece or nephew or son or daughter because they realize it helps them with his or her pain. That's opiate misuse as well. I'll just go to the 2018 National Survey on Drug Use report that almost 10 million Americans over the age of 12 have misused a prescription pain reliever in the past year. Huge number of people are misusing prescription pain relievers, whether they got the pain medication from their doctor or they were given it by a family member or friend, or they took it, meaning stole it or bought it from a family member or friend. In terms of opiate misuse in the United States, this data is slightly dated, but it's about 4.2% on the US average. And the rates are different for different races and ethnicities. In the Hispanic population, it's about 4.9%. And in the American Indian population, it's quite a bit higher, about 6.9%. I mentioned the sources of misused drugs. And when I asked this, when I've given many talks around New Mexico in person to large groups of physicians, because we have a 5-hour requirement of pain and opioid prescribing CME every 3 years. All doctors in New Mexico have to have this CME requirement. I would show this exact slide, and I would, before I show the slide, I would ask the clinicians in the room, okay, so where do you think your patients are getting, the sources of their misused drugs? Do you think, number one, they're getting it from buying it on the streets, buying it from the internet, getting it from their spouse or a relative? They would raise their hand and they would say, definitely buying it on the street. Well, it turns out not to be the case. The biggest piece of the pie is that most sources of misused drugs are when somebody actually is given it without having to buy it, are given it from a friend or a relative. They are they are just routinely over and over. The patient gets it from a doctor, and then that patient gives it to a friend or a relative, and then they misuse that medication. And it's a nice patient because they're not charging them, and that's 47.2%. In smaller circumstances, you can see on the bottom of the gray part of the pie chart, in 9.2%, patients who are getting this prescription from their doctor, they are buying it from a friend or a relative. So what's the take-home message here? The take-home message is we do need to be more cognizant about prescriptions that we are writing for our patients to make sure that they, in fact, are using it for themselves. The blue part of the pie chart is that patients getting their prescription from their doctor. It's the blue pie chart, blue piece of the pie that says 42%. They are taking it from their doctor, but they're perhaps misusing it a bit. They might be using it for their severe low back pain, but they also might be using it a little bit to sleep, or for it makes them feel better psychologically. And if you can see, by the very bottom in the green piece of the pie, bought from a drug dealer or other stranger, that's only 6.2% of the pie chart. So going back to Nora Volkow, she talks again about the collision of COVID-19 and the addiction epidemics. And she talks about that people with substance use disorders are especially vulnerable to COVID-19, that patients with substance use disorders have chronic comorbid COPD, chronic cardiovascular disease, and other respiratory diseases by nature of their kind of chronic substance use disorder. And that risks of addiction epidemics may be indirect and complex. And that during the COVID-19 pandemic, we all knew how patients living in congregate settings, nursing homes, incarceration, were all more subject to COVID-19. And this population is also more subject to substance use disorder as well. Also, patients with substance use disorder have higher rates of experiencing homelessness, reduced access to healthcare and recovery services, higher difficulty obtaining medication. And during the COVID-19 pandemic, we also knew that, first responders, paramedics, and ambulances were definitely prioritizing COVID-19 patients in terms of going to the emergency room. And so patients with substance use disorders were really marginalized when it came to care. I want to now briefly pivot to kind of other chronic medical conditions, not just substance use disorders and chronic pain and suicidality during the COVID-19 pandemic. There's an estimation that there's been a huge excess deaths other than COVID-19 during the pandemic. And this was early on in the pandemic, but this just goes to show you that the COVID-19 pandemic increased other chronic conditions when we could not care for patients because we were so busy taking care of those with COVID. There were decreased rates of cancer diagnoses during the COVID-19 pandemic. Common cancer diagnoses fell sharply during the early stages of the pandemic and continued to fall sharply, suggesting that patients were not getting screened, and therefore when they did get diagnosed, their diagnoses were much more advanced. So not a good thing that there were decreased rates of cancer diagnoses, just that when they got diagnosed, they were much more at advanced stage. Again, suggesting that patients weren't getting into their primary care doctors, into specialty clinics, all things that make a lot of intuitive sense. There were increased rates of heart attacks and stroke during the COVID-19 pandemic. People were scared, might have had chest pain, might have had kind of Prinzmetal's angina, chest pain, stroke-like symptoms. But, you know, do I go to the emergency room? Maybe not. It's already filled. They're not going to see me. I might need to wait 15 hours. My symptoms are gone away. I'm afraid, things like that. And then they might come in with much worse symptoms or maybe not even make it in at all. Many cries for help. So now just turning to the drug overdoses during the COVID-19 pandemic. As you know, as I mentioned, these soared tremendously as patients with substance use disorder were seeking help and could not get the help they need. The American Medical Association issued many briefs talking about overdose epidemic and other concerns during the pandemic. And many kind of editorials and comments about, are we rationing who we care about? That certain vulnerable groups risk being left out in our response to the COVID-19 pandemic. And it just really goes to show you that it's just really hard to take care of everybody all of the time. Just wanted to point out again how chronic pain, substance use disorder, mental health, and suicidality really interrelate. There's a really great hallmark study a little early on, about 10 years ago, with 5,700 adults. It was a US population-based study to investigate pain and suicide. And about 29% of the patients had chronic pain, back or neck pain, or headaches or other non-arthritic pain. And all of these conditions for these patients were consistently related to suicidality. And with these patients, the patients with severe headaches had the strongest association with the suicidality. In fact, people with the chronic headaches in this study were over 4 times more likely than without headaches to think about suicide, 4.6 times more likely to plan suicide, and 6.5 times more likely to have attempted suicide in the previous year. So just a little bit about the interaction of chronic pain and suicidality. And then the interactions of substance use disorder, chronic pain, and social determinants of health, meaning kind of our poverty and homelessness and our built environment, is that many people with homelessness and poverty, many people, actually a disparate number, have chronic pain and substance use disorder. Many are African American and other minorities. And as a matter of fact, a topic very close to my heart, which is kind of climate and environmental justice. Many also live in jurisdictions that are high in particulate matter. And so they're also really being exposed to carbon emissions that also put them at risk for other chronic conditions, such as pulmonary conditions and cardiovascular conditions as well. But there's been a lot of innovations during COVID-19 to reduce opiate use disorder and substance use disorder and chronic pain. As a matter of fact, many methadone maintenance treatment programs began dispensing methadone kind of outside of their clinics when we knew that being outside was much safer than working indoors, even with masks. So many, much of the dispensing happened in many clinics kind of outside when federal regulations were loosened. We began providing an increased amount of take-home naloxone for patients with opiate substance use disorder, and we know take-home naloxone works much better than prescribing, meaning that when writing a prescription for naloxone, if you can actually physically give someone with an opiate use disorder, physically the naloxone, with or without their family member, they will go and teach their family member how to use the naloxone as a harm reduction tool, or that patient will actually go and use the naloxone in their social network and save another person's life. We've been using telebehavioral therapy much more often, and Project Echo, which is a telementoring network which connects subject matter experts to clinicians all over the state. It's available in all 50 states and in over 85 countries now, is providing many chronic pain and opiate management echoes, medication-assisted treatment echoes, and other programs to bring best practices to where clinicians are. There's been increased frequency of checking in on substance use disorder and chronic pain patients, increased social work assessments, and increased frequency of interdisciplinary team meetings. I'm going to pivot now, a little bit pivot to the second half of my talk, and something that's near and dear to my heart with Project Echo is kind of a Project Echo, which, as Dr. Gerber alluded to, is a telementoring network, which again brings subject matter experts in a certain condition, whether it's pain management and opiate, pain and opiate management, to clinicians to meet them where they are, so that they can better learn how to take care of their patients in their local jurisdiction. And it's a combination of didactics, such as what I just provided, and case-based learning. And if you were a clinician, let's say a primary care clinician or a behavioral health provider, and you were attending one of my chronic pain and opiate echoes, or one of the chronic pain and opiate echoes that's available in most states, you could actually present a real case that you're taking care of, a real patient case that's been de-identified and HIPAA compliant, meaning you would not use the name or any identifiers, so that there is no, it's an educational case and there's no privacy concerns. So I'm going to take you through a case such that a case that a similar case that has been presented to me in the past on such a network, and walk you through how we might consider safely taking care of this young man named JR. So JR is a 45-year-old male. He's a former truck driver. He has moderate to severe chronic pain of his low back. His symptoms began when he was about 35 from injuries he sustained as a semi-professional football player. When he was actually in his 20s and 30s. His social and psychological history is such that he's drinking a lot of alcohol, namely a lot of beer in large quantities. And he's having trouble sleeping at night, a lot of trouble sleeping at night with anxiety and depression. And history of kind of chronic anxiety and depression. His family history is that he his parents had been depressed for many years. His mom is still alive, and his dad died when his dad was 55. He suicided. JR's current medicines include morphine sulfate, the long-acting version. He also takes alprazolam for sleep, and he's been taking this for some time now. He takes it every night. And he takes fluoxetine for depression and anxiety. He gets this from his primary care provider. He does not see somebody for psychotherapy on a regular basis. And I guess my questions for you, if you're interested, is to put in the Q&A is there anything that we should adjust with his medications, and what worries you about his psychosocial history? And Jeff?
Yeah, we'll take a moment so people can put some responses in the Q&A if you want to.
And if not, I can go on, whatever you think.
We'll just give a brief minute here.
Sure.
All right, nothing's appearing in. Michael says the history of the father's suicide is concerning.
Mm-hmm. Well, thank you, Michael.
And so does Bernadette Berg, the family history of suicide. Right,
absolutely. Thank you for those. Thank you for those thoughts. So I'll go to that second question first. Thanks, Jeff. What worries you about his psychosocial history? Absolutely, I would agree, Michael and Bernadette, that really worries me, that his father suicided, and that, if he has depression and anxiety, and that he's using, two worrisome medications, the long-acting opioid and the alprazolam for sleep, and is having sleep trouble, and has depression himself, and drinking. I guess the drinking significantly, that he is at increased risk for suicide. And then
we have about 6 more chats coming in. Richard Francis is advising to get more off the opioids onto other pain management treatments, and Margot Gross is asking what has the prior treatment been. Lori Blinderman's asking about the family history of suicide, the combination of benzos and opioids, and the lack of mental health treatment. And Deborah Estercher says medication change and taper off the alprazolam, and consider about sleep hygiene, referral to pain management for injectables.
Thank you. I think I need to refer this patient to all of you. That's all right on. So the question, is there anything that we should adjust with his medications? You are all of you are just spot on. Just as you said, I'm really worried about the fact that he's on long-acting morphine, and that he's not on any neuropathic medication. So he's got severe chronic low back pain. Again, it would be ideal if we knew exactly what type of low back pain. Is it myofascial pain? Is it neuropathic pain? Does he have an X-ray, or what is his exam like? And why is it just long-acting morphine? The combination of the long-acting opioid with the alprazolam is very worrisome. Does he need to be on both? The long-acting opioid and the alprazolam, and the combination of the opiates and benzodiazepines is very worrisome in terms of putting someone at risk for an opiate overdose. So all your questions are right on. I'm going to move on now, if that's okay.
Mhm.
I just wanted to now just talk about, the worrisome things about benzodiazepines, especially in terms of pain management. Benzos are involved in approximately 20% of all opioid overdose mortalities in the early years between 2015 and 2017. And although this is a little dated, the rate of co-prescribing of benzos and opiates quadrupled between 2003 and 2015. And we know that this has increased even more. And we also know that the highest co-prescribing rates continue to occur for females age 65 and over. We also know that the drug overdose deaths involving benzodiazepines with opioids is very high. And it's highest with benzodiazepines with synthetic opioids other than methadone. If you can see that yellow line, overdose deaths with opioids and benzos really has increased from 2015, and it had that huge kind of increase between 2015 to 2017. And now in 2019, there was about over 9,700 opioid overdose deaths involving benzodiazepines. Most of you know this, but the side effects of benzodiazepines for many patients are worsening of depression, sedation, slurred speech, anterograde amnesia, difficulty learning, falls in the elderly, a risk of cognitive decline, tolerance and withdrawal. And then in our pain world, we always talk about the worry of the combination of opioids, benzodiazepines, alcohol, and a muscle relaxant, specifically Risperdal or Soma. And Soma is one specific muscle relaxant, but the metabolite of Soma is meprobamate, which went off the market kind of in the early 70s, which is really a barbiturate, so it's really giving someone kind of a barbiturate, which, as you can imagine, is also a respiratory depressant. So if any of you know colleagues using Risperdal as a muscle relaxant, it really is not a good muscle relaxant, and try to get your patients or their patients off that medication. It's not a great primary treatment for depression. It worsens pain severity, and it's good as a short bridge. And again, with alcohol use, and especially with JR using large quantities of alcohol, it might be worth trying to get JR off his alprazolam. So in terms of alcohol prevalence in patients on opiate therapy for chronic pain, among patients on opiate therapy, unfortunately, 12% reported concurrent use of alcohol, 39% reported concurrent use of sedative hypnotics, and 3% reported all three. And this was one study. And in chronic pain treatment settings, 16 to 25% of patients report past or current history of heavy alcohol use or alcohol disorders. So we really need to ask that question of our patients when we're seeing them for chronic pain, because many patients really are kind of self-medicating before they see us. And there's a lot of good books on deaths of despair. Deaths of despair are very predominant in New Mexico. The deaths of despair include drug overdose, suicide, and alcohol liver disease. Very predominant in areas of the country that are impoverished, and it's really difficult to see. And then here is what I wanted to show you, how when you combine benzodiazepines, opioids, and alcohol, and as your age goes up, the worsening of predicted outcome for a serious outcome in terms of emergency department visits really worsens. So benzodiazepines alone, in terms of patients coming into the emergency room with a problem with benzodiazepine use, let's say respiratory depression or confusion or dizziness, yeah, it worsens as you go up. But as you see the bottom line, benzodiazepines, opioids, and alcohol, as a patient gets older, they're going to run into more and more problems if they're taking all three: benzodiazepines, opioids, and alcohol. So how do you address the problematic benzodiazepine use? You start with screening of problematic use, and well, not only screening, but I really should have put the fourth bullet up first. You really start with a good clinical evaluation, and the clinical biopsychosocial history is really the gold standard. And after that, you can screen, and there's many screening tools, like the audit screening tool, DIT audit screening tool. You can do urine drug screening. The audit is for actually alcohol, but you can do screening. You can do urinary drug screening. You can look at your prescription drug monitoring board at your own state, and you can provide treatment, whether it's psychotherapy, mindfulness-based interventions, cognitive or other short-term psychodynamic treatments, acceptance and commitment therapy, and then treat the underlying psychiatric illness. And then, of course, there are medications for alcohol use disorder. Now we're going to turn back to JR's case. And again, feel free to put in the chat, and Dr. Jeff Katzman is going to help us with that. If you would, Jeff, how might you approach JR's opiate and benzodiazepine use? Would you choose to discontinue one of the medications, meaning the alprazolam or the long-acting morphine? Do you think it is safe for him to use alcohol as well? How might you approach this behavior? What are some of the best ways to monitor his opiate use for pain?
We'll see what comes in the Q&A quickly. We had some more questions that we can get to at the end about the case also,
right.
That I saw potentially from Rodolfo Casals was concerned about the patient's race and possibly the impact that's had on his getting care for his low back pain. And Margot Gross was concerned about community and friendship supports. And John Tamaran is wondering why this patient wasn't getting psychotherapy or being in a support group. So thank you for those comments. And let me see, I'm not seeing any, a new answer. Helena Svedin says maybe the opioid use is caused by a feeling of disconnection to others.
Right.
Yes. So I don't know if you want to get into the answers for these questions.
Right. These are all, maybe save these for the discussion. These are all fantastic. I really think JR would have been best served by being in, some mental health treatment earlier on, but unfortunately he wasn't. And, he was seen by his primary, and he's now kind of being seen with where he is at now. And I think he's using the alcohol and the alprazolam really just to kind of get him through each day. But I agree with all the questions, definitely. So how I would approach JR's opiate and benzodiazepine use, I really would talk to him about the fact that his use of alcohol really worries me. His continued use of alcohol would not allow me to continue prescribing the opiate and benzodiazepine use, and that I would need to have him on a contract for him to discontinue the alcohol use. And we would need to really also, because of the worry about the combination of the opiate and benzodiazepines and the fact that he's on both and can cause such respiratory depression, we would need to really choose one. And obviously, as someone said before in the Q&A, it would be much better if he was on a neuropathic agent like gabapentin or pregabalin or an SNRI, perhaps an SNRI like duloxetine instead of the fluoxetine. I would need to work with him and be patient-centered and understand which medication, does he want to wean off the opioid or does he want to wean off the alprazolam? Sometimes it's easier if you put the choice, give the choice to the patient, but really the alcohol needs to be discontinued. So the alcohol definitely is not safe. And I would give him referrals to treatment. And then what are some of the best ways to monitor his opiate use for pain? A controlled substance contract, as you know, is not a legal contract, but it can really educate patients as to the kind of the fact that opiates are short-term therapies for pain. It can give it. It's a way that you can discuss side effects and benefits of opiates for pain. You can discuss an exit strategy when you're talking with someone about a controlled substance contract. You can, mark a sole pharmacy for the patient to use. You can talk about the fact that if the patient needs to increase their dose or ask for an early refill, that they need to do that with you and only you. And then you can talk about the fact that you might need to ask for pill counts or a urine drug screen. And wherever you're calling in from, your state, and Connecticut most likely has specific rules and regulations regarding pain management. I just wanted to show you here that with our Project ECHO various Project ECHO teams, we worked with the Army for about 8 years, and we helped them launch ECHO pains all over the United States and over 20 hubs in Western and Eastern Europe and in Asia. And they have weekly Project ECHO pain and opiate management clinics successfully throughout the globe. I helped them do a patient level study showing that the clinicians who participated in ECHO pain versus the Army and Navy clinicians who didn't participate in ECHO pain, the clinicians, the patients whose providers participated in ECHO pain had over a 23% decrease in opiate prescriptions, and the dose of their opiate prescriptions also declined significantly. And not on this graph, but also significant, was their decline in opiate and benzodiazepine co-prescribing. So we had some good results that education through platforms like Project ECHO can really educate clinicians on best practices, pain and opiate management. Now turning to kind of how to avoid long-acting opiates and provide naloxone. As you know, the CDC guidelines in 2016 talked about using non-pharmacotherapy first, followed by non-opiate pharmacotherapy second, and only initiating opiate therapy with short-acting preparation if medically indicated. So JR was on a long-acting preparation, which really wasn't best practices pain management. And not only that, he was not on any other pain medications. And I'm not sure if he had physical therapy or acupuncture or chiropractic treatment or any other kind of non-pharmacotherapy. But the role of long-acting formulations, it's really not for acute pain treatment. It's really more for patients who have such severe pain or for cancer or hospice treatment. And methadone is really a long-acting opioid that really should only be used by primary care providers or pain medicine specialists because it has very different half-life, and it has very kind of risky side effects. It can prolong the QT interval and put a patient in a torsade de pointe, and it can really increase the risk and liability for a primary care provider. As you know, it's extremely effective medication for opiate use disorder, and it's used most widely in methadone maintenance treatment centers. But because of its long, variable, and unpredictable half-life, it's very difficult for primary care providers who don't use opiates much to begin using it for chronic pain management. Naloxone, on the other hand, should really be used for patients who are on opiates for chronic pain, and it really should be used every time in patients who have an opiate use disorder. And JR has depression and anxiety, and not only do we need to do a very good patient-centered biopsychosocial history, but he might need some screening tools as well, such as a PHQ-9 and a depression assessment that you all know of. And we want to make sure and see whether or not he fulfills the category of having a DSM diagnosis of depression. We also want to make sure that JR does not have suicidal ideation himself, because patients with opiate use disorder have a risk of suicide 13 times greater than those without opiate use disorder. We want to screen for suicidal ideation and consider providing sensitive and compassionate screening to every patient. We want to demonstrate interest in patients' answers, and we want to listen actively without passing judgment or rushing the person or interrupting or giving advice. There's many components of a suicide screener. We want to identify current suicide risk factors, such as JR's chronic pain, his drinking, the fact that his father suicided. We want to identify protective factors. Does JR have a spouse? Does he have kids or grandkids? Does he have a job? We want to inquire about suicidal ideation, intent, and plan. And then we want to rely on your own judgment, your own practitioner judgment of risk level and plan for clinical intervention. There are many screening tools. We mentioned the PHQ-9. There's the patient safety screener. There's the suicide ideation screener. And then there's the Columbia Suicide Risk Tool, which we're using at University of New Mexico. So we're moving on to the case again, and maybe we'll save some of the Q&A, Jeff, to the question to later on when we have a discussion. But do you think it would be important to screen JR for suicidality? I think many of you have already said yes, definitely. Do you think he would be willing to be evaluated by a mental health clinician? I'm going to definitely recommend this, and certainly hope so. Do you think he would be interested in addiction services and or other interventions? Well, we have to see if he meets the criteria for an opiate use disorder or alcohol use disorder, and then see if he would be interested in these services. And would naloxone be a good idea? Well, if JR stays on this long-acting opioid, naloxone would definitely be necessary. Many substances, including benzodiazepines, opiates, and alcohol, contribute to central nervous system depression in combination, and may significantly increase the risk for accidental overdoses. And you need to carefully assess the risks of drug and drug interactions as you consider prescribing for pain and potentially and diagnose substance use disorder. I just want to turn to now to just some topics of stigma before we get to the discussion, if that's okay. Just about 3 more slides, if you will. JR was not on any opioid medications. And he might benefit, in my opinion, by a tricyclic medication if we did an EKG and his EKG was okay in terms of no prolongation of his QT interval. He might benefit from converting his fluoxetine to a serotonergic noradrenergic reuptake inhibitor. He might benefit from a neuropathic medication such as gabapentin or pregabalin. He might benefit from a non-steroidal medication if his back pain was found to be myofascial or facet related. And he might benefit from a muscle relaxant if he had paraspinous muscle spasm. Obviously, we need to do a better workup of the cause of his low back pain. And not all of these medications should be tried at once, obviously, one at a time, as we're trying to perhaps wean him off the opiates if they're felt to be not necessary. I just want to, you all have these slides in your chart, but I just want to close by talking about the stigma of substance use disorders. In that substance use disorders are the only conditions in which lapse in treatments is grounds for dismissal, where substance use disorders are the only conditions in which known life-saving treatment is withheld or rationed, that not all medications are offered, that many times the less effective or even no medications are offered, that medications are withheld based on, quote, personal feelings or, quote, moral objections. Substance use disorders are the only medications in which active disease is considered to be a crime problem. Substance use disorders are the only conditions in which patients may be expected to discontinue a known effective medication. And substance use disorders are the only conditions in which many times there is no or limited insurance coverage for effective treatment. And finally, for substance use disorders, detoxification is not treatment. Substance use disorders are chronic illnesses. We know effective medications exist, however, barriers remain to treatment, and we must consistently work to remove these barriers. So just a little bit today about chronic pain, substance use disorders, specifically opiate substance use disorders, mental health, suicidality, and the interrelationship. And wanted to let you all know that I have a lot more slides in this deck, and I wanted to just have them for you so you can keep them for your reference. Thank you, Dr. Gerber, Dr. Katzman, Dr. Grote, Anne, and Jane.
Thank you, Dr. Katzman, for a world tour of multiple coexisting issues and how they interact with each other. Thank you so much. And we'll now get started on the Q&A part of this grand rounds. Please, everyone, submit any questions to Dr. Katzman and the panel up here using the Q&A link at the bottom of your screen. We have now a panel with us. We have Dr. Andrew Gerber, who I introduced before, our our chief psychiatrist and president at Silver Hill, our chief clinical officer, Michael Grote, and one of our attending psychiatrists, Ryan Wade, with a strong background in addictions, having recently graduated from the Addiction Fellowship at Yale. So welcome to all of you. And Andrew, I'll hand the baton to you to see if you've got first comments or question to start us off as people type in some questions.
Sure. No, thank you, Jeff. And I'll be brief because I really want to get to others who are more informed than I, and also to the questions. I mean, already from your question earlier, Dr. Katzman, so many people are involved, which is great. Thank you for just a powerful talk. And I think it's distressing, to be honest, as a physician, as a psychiatrist, to realize the extent to which I think we as a profession have been part of the problem. And it's that I think is a powerful message. Not to suggest you were being scolding us for that, but I just think it's so important that people hear what you're saying. And listen, physicians and certainly psychiatrists are no different than any other human being, right? We tend to look for data that confirms our own biases, and to find fault and blame elsewhere rather than ourselves. And I just want to point out a few things that you said that particularly something you said right at the beginning that I just found so powerful. 90% of misused opiates, if I was reading that pie chart correctly, and you tell me if I'm wrong, come from physicians, right? About half of those, or a little more than half of those, from a physician who was prescribing for somebody else, and the remainder from someone who was prescribing in some way for the individual who misused them. But that's 90%, right? 6% was from drug dealers, right? At least as it's conventionally defined. So we have to be part of the solution if we're a part of the problem. And I'm not saying that it's intentional, obviously, but for most doctors, but our lack of attention to this is clearly problematic. And I think you have such a helpful way both pointed at the problem and given us some of the tools. I think you're focusing on chronic pain is obviously so crucial. I mean, the numbers you put up there in terms of the multiples of risk in patients with chronic pain are really profound. And if you're thinking from a public health perspective and where do you want to put the attention and the money, clearly it needs to go into these very, very high risk groups that you're pointing out. So I know what I'm saying is obvious to you, but I sort of saying it more for myself. And then the last thing I just wanted to comment on was something you said right towards the end around the stigma question. But again, I just found this so powerful that it is so tempting for us as physicians who like to have solutions, to have cures, to think of detox as treatment. And I thought you said it so powerfully. Detox is not treatment, right? Detox is just getting you through a very acute medical phase. And treatment in some ways really begins after. And we all know, those of us who work in this business, which most of the people on this talk today, know how many patients say, all I need is a detox and I'm done. That's all, right? And of course, I think our messaging is so crucial to say that, well, that's not treatment. And then the very last thing I'll say, and it's just it's a thing I know you will agree with. So I will point out that you said effective medications exist, but of course it's not just medications, right? As you pointed out so many times during your talk, it's effective treatments. And some of our most effective treatments are forms of psychotherapy. Of course, the broader form of psychotherapy, meaning not just the one sitting across or a room from each other, but all the other kinds of milieu therapy, of support groups, of family therapy, all the other ways that we have of keeping people or minimizing their risk, which never fully goes away, of course. But I think that is certainly what we try to do at Silver Hill, but there's a lot more work to being done. And I'm so grateful to you for calling our attention to all of that. So I will stop and turn it back to you, Dr. Jeff Katzman, to and obviously, Joanna, if there's anything you wanted to say, that'd be great. But I really want to hear from others.
Joanna, you have any quick response?
Thank you. No, thank you for all that, Dr. Gerber.
Michael, do you have any reactions to the talk from your window of the world?
Okay, sure. Well, again, thank you so much, Dr. Katzman, for this brilliant review of the Tetrad. And I love the way that you framed the crises, the tale of two crises. I think really stood out. And I think a couple of very quick things that stood out to me. One was that you were highlighting the systemic nature of these deaths of despair. And it makes me think about a few weeks ago when I did grand rounds, thinking about the tragedy of suicide and the connection, as about, in terms of despair. And that it's going to take a whole system to address. And that, as Dr. Gerber points out, can zoom in on the role of the physician, which is important, the role of the therapist and all the different types of therapies. I think as you're pointing to truly a wicked problem as defined by something that's extraordinarily complex, and we're trying to figure out where can we be most impactful in making a difference. And I think you've given us some direction today, and I want to thank you for that.
Thank you.
Hey, Dr. Wade, welcome to the panel. And any thoughts or questions from your lens and everything you do at Silver Hill?
At first, thank you so much for this. I thought it was excellent, and I think there's not enough attention being paid to how this is actually worsened during the COVID pandemic. You know, I think there's good reason we were paying attention to COVID and not necessarily paying as much attention to the opioid epidemic, though it's clear that it's worsening during that time frame. So, and not a lot of attention or to the data out there is being paid. So I appreciate that. I also wanted to touch on the last part that you were talking about, the stigma related to substance use. That's actually a grand rounds presentation I'm doing towards the end of the year, is specifically on stigma and substance use disorders. So that's something that's particularly notable to me. And a lot of what you said rings true, unfortunately, in terms of people withholding treatment and kicking people out of treatment for missing appointments and or not following instructions. You would never withhold someone's insulin because they won't stop eating cake or something like that. There's an amount of this that's we're trying to reduce harm by giving treatment, and it's similar to managing a lot of other chronic conditions. And in those instances, we're never withholding care like in other fields of medicine or with other conditions. And so from our perspective, what we can do is the medical community, I think that's one of the highlights to hit, is that we should be doing everything we can to keep people engaged, keep people in treatment. And at some level, we're all dealing with an amount of risk. And I think that's where some of this comes from, is the fear of risk of continuing to treat despite the instability. And it's kind of what we do in medicine. And so I think it really should be no different. And so I appreciate you calling attention to that.
Thank you.
So we have some questions in the chat too. I just want to say also, when I hear you talk about this, Joanna, it does every time make me think about how in psychiatric training, we're kind of shielded from understanding about approaches to treating pain, that we have many requirements in terms of inpatient and outpatient psychiatry rotations and geropsychiatry and child psychiatry and substance use, all connected to fellowships. And psychiatrists can go into a pain management fellowship from a general psychiatry residency, yet there are no requirements really about learning about pain management in any way in a psychiatry training program. And even more, we are really shielded from prescribing or thinking much about opioid use. And I think many psychiatrists kind of learn to, that's not my business. So I think that there's a way in our training that we need to become more aware of exactly what you're talking about.
If I can just add on that, a big push of mine, or a big kind of interest of mine, is like 5 years ago, there was a big, when the CDC guidelines came out, there was a big call or a big push to, teach people, if you're prescribing more than 50 or 90 morphine milligram equivalents on a patient, oh, that's too much. Or if the patient is on more than X amount of opioids and they're on a benzodiazepines, that's not good. You need to get them off these two medications together. But clinicians did not have tools in their tool chest to learn, what do I use instead of the opioids? And my big push for the last many years has been, not only teaching primary care clinicians about, the interrelationship between chronic pain and substance use disorder, but what they can do instead of writing that script for Vicodin. What non-pharmacotherapy can they use? Would JR have been better early on to have, seen a physical therapy, to have been given a really good, robust diagnosis for his chronic pain, to have been able to see a psychologist and a physical therapist early on and understand how, maybe his low back pain was interacting with his depression. And maybe if the physical therapy wasn't entirely beneficial, he could have then, seen a chiropractor. And then if that wasn't working, then maybe he would have benefited from gabapentin. But then it wouldn't have been, he would never have even gotten, into the opiates in the first place and down the road of the opiates and the benzodiazepines. So really teaching clinicians kind of safe steps all the way through. I think that's because we're so used to teaching no opiates and benzodiazepines, but we don't really give people the tools to do it otherwise. So I agree with you.
Yeah, thanks. Just to build on that, in the Q&A, there are suggestions of various psychotherapies and ways of connecting really for patients like JR, and they're mentioned in terms of peer-to-peer through AA or other clinical modalities. There's a shout out to neurofeedback, to NA, and to meditation. And I think, as you've alluded to, as Dr. Gerber was talking about, the understanding all of these various psychotherapies and their role, and how you do integrate them is really part of that tool chest. We have a big question here from Richard Francis that I'll read to you. I think as our world goes along, we're even going beyond the Tetrad here. So the question is, any thoughts about what suffering addicted patients suffering pain in Ukraine is occurring as a result of the war, displacement, and dispossession, and how we can help, and would telepsychiatry be of help?
Yeah. I think telepsychiatry would be of help. I think an echo program to connect with mental health providers or frontline clinicians could help. I think they're dealing with so much, I can't even possibly understand the level of pain, an existential pain that they're dealing with. But I do think that programs like remote programs and remote platforms could be very, very helpful. Jeff and I have connected with a group, a resiliency group, to try to put an echo together in Ukraine and Poland to work with folks, work with mental health providers on the ground. But I think something where we can kind of connect mental health providers in Ukraine could be beneficial. I think any support, any meaningful support, yes.
Thank you. There's also a question in the Q&A about the use of ketamine and ketamine-assisted psychotherapy, or ketamine for pain relief, and would that go some way to reduce the anxiety and reliance on other medications? I don't know, Dr. Katzman, if you have comments about that, or other people on the panel might have ideas.
I can't comment on ketamine and psychiatry so much. Ketamine is helpful in certain pain syndromes, such as really refractory complex regional pain syndrome and certain severe neuropathies. But in terms of the psychiatric aspect, maybe someone else could comment.
Yeah, I don't mind commenting on that a little. I think that with the specific situation, I'm not familiar with of any literature that is treating chronic pain as well as using it for psychiatric concerns, like treatment-resistant depression. I don't know. There may be some literature out there about treating both of those simultaneously. I'm not familiar with it. I haven't seen anything about that. That there is some literature, as you suggested, Joanna, that using it for certain chronic pain conditions. I think it certainly could be of utility. We find with those that are having difficulty with depression, it can be a pretty rapid improvement a lot of times. The concerns I'd have more so with this case specifically is you tend to need infusions frequently when you're first starting, 2 to 3 times a week, and he's a truck driver, he's likely not home in a very stable pattern, as well as the fact that combining it with all the other things that he's currently, like he's taking alprazolam as well, and he's drinking a good amount of alcohol. Combining all those things together, there isn't a whole lot of safety data that I'm familiar with, in terms of using it with someone who's drinking so heavily. So I think we'd have to make some adjustments from where the presentation is currently before we consider utilizing ketamine. It is kind of like it's a very thoughtful approach though, in terms of like, hey, we might be able to knock out a few of these things with one substance, so to speak, one medication, so to speak. Though the evidence for using it with all this stuff in combination, just we don't have that evidence yet, as far as I'm aware.
Yeah, thank you, Dr. Wade. So it is time for us to end. I'm going to end with the last comment in the Q&A. That's from Kristen Brown, who said that unfortunately she needs to jump off, but thank you for this incredible lecture. So let me build on that. Joanna, thank you so much for really an incredible lecture. Thank you, Dr. Grote, Dr. Gerber, Dr. Wade, for joining and helping me today facilitate a really great discussion. And thank you all for chiming in today and each time that you do. And I hope you're enjoying this Grand Round series. As a reminder for those wishing to receive CME and CEC credits, please complete the evaluation survey that will automatically pop up in the browser as the webinar ends. We talked about isolation and loneliness today, and I know of no other greater cue than what happens at the end of our Grand Rounds when we're all feeling connected, and then I say the word and Jane pushes the button and we're suddenly disconnected and left alone in our rooms. But it's about to happen. As a warning, this now concludes our Grand Rounds. Thank you, everybody, for being with us. Thank you, Dr. Katzman, and everybody else.
Thank you. Thank you.
Thank you all.